session from National Institute of Nursing Education, PGI, Chandigarh, where she has received gold medal for her academic performance in graduation. She has also done MBA in hospital management and enhanced nursing care post-graduation education in critical care nursing, Canada. She has also received Canadian Nurses Association certification in medical surgical nursing. Her research interests are in critical care nursing, internationally educated nurses transition to Canadian and US nursing, virtual simulation, and futuristic nursing approach. She has total 7 years of clinical and teaching experience in teaching Canadian nursing students and IENs. And thus, I welcome Mrs. Taran Kaur for our international webinar. So over to you, ma'am.
Thank you so much, Aman. And I want to say good morning, India. How are you guys? Good? So I know you guys are on mute, but you can keep chatting. I'm going to look at the chat box. But before I begin, I would like to say heartiest thank you to Aman, who was in touch with me for giving me this great opportunity to come and interact with you guys. I hope you are hearing me clearly. Can you hear me, Aman? Is all good? Okay, perfect. It's very important. Nursing is a dynamic profession and it keeps on changing, and specifically keeping COVID-19 in mind. So I think it's a great job. So great job, guys. Thanks for organizing this. So I'm going to start my presentation, and I'm a kind of a person who likes to interact with the students rather than just me chit-chatting here. So if you want to post something in the chat box, as I said, I will have a look at it, or you can also unmute yourself and ask me questions, right? So I'm going to really appreciate that. So Aman, do you want me to share, or do you want to share do you want me to share the slides?
You can share. If there is problem, I will share from here. You can share. Perfect. You can try sharing from there. Yeah.
Perfect. Sounds good. All right. So my question is, before I move on to my PowerPoint, is guys, how many of you have actually worked with a ventilator? That's my question. If you just want to type it in a chat box, like that's something which I would love to know, so that keep typing, or unmute yourself, or tell me if you have ever worked with a ventilator.
Yeah.
Or are you scared of ventilators? Right? Are you scared?
No, we have worked. Yeah.
Yeah, I'm listening that in the chat box it's here, we are students. All right, so welcome students, or whether you're a staff nurse, whether you have worked with a ventilator or you haven't worked with a ventilator. My goal for today's presentation is that you take home something today, right? So even if you learn something, like as I said, even one thing, I would feel that, my presentation is accomplished and I'm successful, right, for doing that. So as I said, please ask me questions. Don't hesitate. I look forward for your questions. So I'm going to start my presentation here. All right. Can you guys see my screen, Aman? Is that okay? Can you guys see that? Yes?
Yes, ma'am.
No? Okay, perfect. Yes. All right. Perfect, guys. So the topic for our presentation today is a ventilator, a challenge for non-ICU nurses during COVID-19, right? So that's the topic which we are doing today. And I already asked you a question, have you ever worked with a ventilator? Because I remember my time when I started working in intensive care units, right? That's the biggest phobia or the fear people have with the ventilators. And keeping the current pandemic in mind, like there can be a need where non-ICU nurses might have to operate or work with the patients who are on ventilator, right? So our goal is to get you guys settled down in that particular topic and to help you understand a little bit of basics about the ventilator. So the objective for today's class is we will be understanding some ventilator associated abbreviations. We will be understanding some basic ventilator settings, some basic ventilator alarms, and learning to assist the physician during intubation. And what are the trends and management of COVID-19 in Canada, right? Because I'm currently living here, so I'm going to talk about the scenario and the situation. So before I begin, I would like to just kind of brush up with the respiratory system and the functions and how that system works. It's just going to help you guys understand, right? So you should know that when we all breathe, so what's happening in our body, right? So what is the functions of respiratory system? So respiratory system, which means your lungs, helps you in oxygen transportation, respiration, ventilation, and gas exchange, right? So here, for a moment, what I want you to do is I want you guys to take a deep breath here. I'm not joking. I really want you to take a deep breath and just feel what's happening. So when you take a deep breath, guys, what happens? If you imagine, or if you just, think, what's happening is that your chest cavity is coming out, and what's happening is your diaphragm is going down, right? As a result, what happens is you're making a negative pressure in your thoracic cavity. As a result of that, air from the atmosphere goes from the positive pressure to the negative pressure, which is inside your lungs, right? That process is called as inhalation. And then what happens is when you exhale out, what's happening is, if you feel, your chest cavity is going back, your diaphragm is coming up. So this means it's kind of squeezing your thoracic cavity. And as a result, what it is creating is creating a positive pressure and forcing the air out, right? So that's the basic goal of our respiratory system. This is what we do. Then what happens in our alveoli, right? So alveoli or alveolar sac, or these are the different names, right? These are the tiny balloon-like structures which are present in your lungs, and that's responsible for the air exchange, right? So and you know that all the organs in our body, they need oxygen and they need glucose, right? So those are the two things which every cell of your body wants, right? And that's what the respiratory system is doing for us in our body. So before I move on, I just want to touch base. I know it looks huge and a lot, so please don't get panicked, because these are the certain simple abbreviations which you need to know before you even move on to operating a ventilator, right? So the number one thing you should know, I remember when I started working in an ICU, the first time I was doing physician's round, and the first question the physician asked me was, what is tidal volume? And luckily I knew at that time. So just want to share that that's so important. You should know about these volumes, right? So tidal volume is, guys, this is the volume of air inhaled or exhaled with each breath. So I'm just going to give if you want to do little calculation on your own. For example, the tidal volume is 5 to 10 milliliters per kg body weight. So if I say, let's say the physician is telling you that we have to set a ventilator at 10 ml per kg body weight, right? So, and your client weighs, let's say 50 kilograms. So what do you think is the total tidal volume for that client? 10 multiplied by 50. So this means the tidal volume is going to be what? 500 ml for that particular client, right? So that's the number one thing you should understand. So that's the volume of air inhaled or exhaled just in one breath. Then the second thing which is important for you to know is, I'm just going to move to the next slides. There are different volumes like IRV, ERV, residual volume. So I'm going to share the slide with Aman and she's going to share it with you guys. However, as I said, tidal volume is the number one important thing you need to know when you're working with a client on ventilator. Next, you should know is what is the vital capacity, right? So vital capacity, you can see it's the tidal volume, then we have the reserve volume and expiratory reserve volume. When we add all those things together, that makes your vital capacity, all right, of the lungs. And so next is the TLC, which is important. So VC is important, guys, and then your TLC is important, which is the total lung capacity. So total lung capacity is, again, we are adding all the volumes and you can see approximate is 5800 ml. And TLC may be decreased when the patient have the restrictive disease condition like atelectasis, pneumonia, COPD. So in that case, what happens is the total lung capacity decreases when the patient suffers from those disease conditions. So next is, it's very important for us to understand about the partial pressures, right? So partial pressure, as I discussed, is the atmospheric pressure. So just like when we just began this class, I told you guys to take a deep breath, right? So what was happening? I told you when you are inhaling, what's happening is, as I said, again, your thoracic cavity is coming out, diaphragm is going down. You are increasing a space and creating a negative pressure, right? And air has a tendency to move from higher pressure to the lower pressure, right? So that's why the patient will inhale oxygen from the atmosphere into the lungs, right? And if we see our atmosphere, the major constituent of the gases is nitrogen. And then after that, we have oxygen, argon, carbon dioxide, and other gases. So, and if something is going wrong within the patient's, let's say, thoracic system or respiratory system, as a result, what's happening is sometimes those pressures are affected as well. These pressures also help in the simple process of diffusion, right? Diffusion means the oxygen will move from higher concentration to the lower concentration. So when you guys inhale, the oxygen is higher in the alveoli, right? And then the oxygen content is lesser in the blood capillaries. So as a result of that, what's going to happen? The oxygen will move from alveoli to the blood capillaries, and blood capillaries have higher concentration of carbon dioxide. So as a result, carbon dioxide is going to move from blood capillaries back to the alveoli, right? So that's the exchange which is happening with the help of the partial pressures inside our body. So another interesting thing, and again, I love to relate the stories from my own personal experiences. Like when I used to work in ICU, I was like always very curious and excited to know, oh my God, I want to read this value and I don't know what this is about, right? So you should know the number one, another important thing you should know when you become nurse in ICU is you should know how to read ABG. Sorry, that's not a part of the presentation today. I would love to do it sometimes if you give me the opportunity again. But this is called as arterial blood gases, right? So this is something which is very important for you guys to understand when you're working in intensive care unit, right? So another thing, interesting thing is these abbreviations or these letters can make a huge difference. So you can see capital A or uppercase A is for alveolar, right? We use small case a for arterial. We use small v for venous. Oxygen is O2, right? And CO2 stands for carbon dioxide. So these are the little abbreviations what we use. So what do you need to know? What's important? That's what students, they ask me all the time. What's important? This is important for you guys, right? The box which I'm making here. What does PaO2 means? PaO2 means partial pressure of, it should be oxygen. Partial pressure of oxygen in the patient's arterial system, right? So this should be oxygen. Sorry about the mistake. And then PaCO2 stands for partial pressure of carbon dioxide in the arterial blood. And then PVO2 stands for partial pressure of venous oxygen. And then PVCO2 stands for partial pressure of venous carbon dioxide in the patient system. Okay. So, do you guys have any questions so far? I'm just gonna have a look at the chat box. Do you guys have any questions you can throw me? Okay, not so far. All right. Okay, guys. All right, so next is we already talked about partial pressure, guys, so I'm just gonna move on. So it's a simple thing which I explained to you is when you are inhaling oxygen, the pressure of oxygen is higher in your alveoli, right? So this is your alveoli or alveolar sac. And the partial pressure of oxygen is higher here. And so as a result, what's going to happen, oxygen is going to diffuse from alveoli to the capillary, right? And whereas capillaries, they have higher carbon dioxide content. So carbon dioxide is going to move back from capillaries into the alveoli where the gas exchange is taking place. So coming to the very interesting topic is what's happening with COVID-19, right? That pandemic has created a worldwide, as I said, trouble, and this virus is creating. So let's just read what this virus is doing, guys. So coronavirus is, COVID-19 is a pandemic caused by severe acute respiratory syndrome, coronavirus 2, right? So this is basically SARS-CoV-2. That's the virus which is causing this famously COVID-19. So what happens in this, you need to understand, whenever this virus invades our lungs, right? So it can start anywhere from, the journey can start anywhere from nose, mouth, eyes, and then it can travel down to the lungs, right? And travel down to the lungs, and then specifically where? In your alveolar sacs, where the gas exchange is taking place. So this virus is the antigen, right? So you guys, and I hope you guys understand the immunity, that whenever some foreign particle enters inside your body, that's called as antigen, and your body attacks it with the antibody, right? So in that process of attacking, the immune response can create or send lots of macrophages, right? Because that's a response of immune system. It can send cytokinins, some inflammatory signals, right? And reduce surfactant. So what's going to happen is at the alveoli, there is going to be an inflammation which is going to take place. So when there is inflammation in the alveoli, when there is a fluid collection in the alveoli, and there are lots of macrophages which are attacking the alveoli, what's going to happen, guys, in that case? In that case, there is going to be impaired gas exchange, right? So if somebody asks you, what is your top priority nursing diagnosis? So your top priority nursing diagnosis is impaired gas exchange. So imagine if the gas is not exchanging, as a result, you know what's happening. The patient is not getting oxygen, right? And that's the biggest trouble. So I hope you guys understand, like, this is in a very simple nutshell, this is what COVID-19 is causing. This is causing like all this inflammatory process in the alveolar sac. And as a result, what's going to happen? There is no air exchange. And you know that body needs oxygen all the time, right? So if the body is not going to get oxygen, body is going to be deprived of that. And patient would have the various clinical presentation. Patient would have like hypoxia. Patient would have like dizziness, syncope. Patient would have, like, as I said, sometimes altered consciousness level or altered neurological status, right? So if that's what is happening, patient needs to be admitted to the hospital. So now coming to the mechanical ventilation, right? So what do we do? If somebody is coming to us with COVID-19, the patient is respiratory distressed, patient is having difficulty to breathe, then what do we need to know as nurses? So mechanical ventilation may be required for various reasons, right? We talked about it, like not just for COVID-19, we can use it for, like, when the patient has any kind of surgery, right? When the patient has head trauma, and when the patient is into ARDS. ARDS stands for acute respiratory distress syndrome, right? And all those complications can occur with COVID-19. So, as I said, what clinical manifestation or the picture you will look into it? Your patient will have decreased PaO2, right? So I hope you understand this. PA stands for partial pressure of oxygen in the arteries, right? So in the arterial blood, PaO2 is going to fall down, and increase in the arterial carbon dioxide level. So opposite is going to happen. Oxygen is coming down and carbon dioxide is going up, in a simple language, right? And that's what is kind of happening to your patient. And now you know that patient probably would need as mechanical ventilation, right? So what is the criteria? So this is the general criteria, guys, which we use. So when you do the ABG analysis on the client, if you see that the partial pressure of oxygen is less than 50 and the vital capacity is less than 2 times the tidal volume, right? And if the patient's respiratory rate is 35 per minute, I'm talking about the adult client, and I hope you know your normal vital signs. The normal vital signs for the normal respiratory rate is 12 to 20 per minute in an adult. So if the patient is going into tachypnea, which means the respiratory rate is higher than 20, then that also indicates that patient is going into respiratory distress. So what are the contraindications? And as I said, like, I'm keeping more of Canadian perspective into it. We can't put the patient on a ventilator if they don't have a desire to, like, if they don't give us consent, right? So here the patient has a right to refuse the care. Medical futility, quantitative or qualitative interventions that are unlikely to produce any significant benefit for the client, or reduction or termination of patient suffering or the pain, right? So those are the different indications where we cannot put the patient on ventilator. Now, classification of ventilators. Guys, this ventilators is itself a huge course. I have done the specialization in critical care. It's as I said, it's a whole 1-year program or 2-year program in some course like colleges. But just as I said, giving you a very nutshell point of view in just this 30 minutes is that ventilation is of 2 types, basically, right? One is the negative pressure, another is the positive pressure ventilation. So what happens in the negative pressure ventilation, right? So I'm not sure if you read that in your med-surg books, but it's there. The very famous one we have is the iron lung and the pneumo wrap or tortoise shell, right? That's what we have. So what happens in negative pressure ventilation? So negative pressure ventilation exert a negative pressure on the external chest It's simple to use. You don't have to intubate the client. And it's primarily used for chronic respiratory failures where you know that you have to keep the patient on the ventilator pretty much for the rest of their remaining lives, right? You have to support them on that, right? So, but this is a very conventional old method. We don't use it anymore. So I'm just gonna share a little bit of more information here. So if you see here, earlier we used to use like iron lung, and I think this was discovered somewhere in 1869 or something like that. Pretty old ventilators. So, and you can see that this is all looks like a space capsule, right? Yeah, no, we are not sending him to space, but I'm just saying that it looks like a space capsule. And you can see what's happening is that this chamber, which is there, is kind of exerting a negative pressure so that on the whole body, or sometimes just on the chest, you can see in the tortoise shell or the pneumorap. So what's the thing? Like, just like you are doing the normal inhalation process, the way we started our class, it's the same principle they are applying here. They're just using these different gadgets to create a negative pressure so that the air from atmosphere, the oxygen, can go inside the patient's lungs, right? That's what is the goal of negative pressure ventilation. However, nowadays the technology has advanced. We are, as I said, in 21st century. Nowadays we have positive pressure ventilators, right? That's what we have. So for these ones, again, this is two types of ventilations which we can provide to the patient. One is the non-invasive ventilation. Non-invasive means you don't have to put any endotracheal tube. You don't have to put any tracheostomy tube. It's non-invasive. And the second method which we do is the invasive one. So let's just go by one on this. So non-invasive, as you can see, positive pressure ventilation can be given via face mask that covers the patient's nose and mouth. Most of the time, like you would see patients who have sleep apnea, right? Those are the patients who are given like this continuous positive airway pressure, right? And then we have like bi-level positive airway pressure where the patient, as I said, is again, given two different pressures on inhalation as well as on exhalation, right? So in this one, you can see we are not putting any tube in the patient. So that's why it's called as non-invasive, but we are forcefully inserting the air into their respiratory tract. That's why it's called as positive pressure ventilators. So next is the invasive one. So you can see in this picture, this guy has the endotracheal tube inside, right? Inside the trachea. So when we put the tube inside, and then when we hook up that machine to the machine, that's called as the invasive positive pressure ventilators. So there are like different types of ventilators. We have pressure cycled. So what does the pressure cycle do? It delivers the pressure is the focus. So for example, if doctor has ordered that we need to set the pressure at, let's say, I'm just making it up here, 20 centimeters of water, let's just say. That's the goal of the ventilator, is that it's going to deliver that much amount of pressure. Second is time cycled. So that's terminate or control inspiration after a preset time. Most ventilators have a rate control, and that determines the rate of respiration. This is basically used for newborns and infants. And the last one we have is the volume cycled. So you remember we just discussed before about the tidal volume, right? So this is the volume base. So just like you would know the patient's body weight, and then you will be calculating the tidal volume of the client, and then you set up the tidal volume for each breath, right? So the ventilator will deliver the ventilation until you reach that particular volume, right? So it's a volume-centric ventilator. So now next is ventilator modes, how the breaths are delivered to the patient, right? So there are different modes, guys, and I don't want to put you in any kind of panic attack here, but we have like assist control ventilation, intermittent mandatory ventilation, SIMV, pressure support, airway pressure release ventilation, and proportional assist ventilation, which is a pretty new one here, which we are using in advanced countries. So, but I will just cover the basic one so that you have the basic understanding of the ventilation. Number one is, guys, assist control ventilation, right? What does that mean? In simple language. In simple language, it means that patient will do nothing. Patient has zero respiratory effort. Patient is not doing nothing. You have to set everything for the patient. So if you see here, you operator, which means you. In Canada, guys, it's different. Like in Canada, we have respiratory therapists. They are the ones actually who primarily deal with the ventilators. Then physicians and nurses are also like ICU trained nurses. They work with the patients. But when I was in India, I worked in India in intensive care unit. That was a time like the orders were written by the physician. However, as I said, we used to look at the monitoring and the setting up and just check the ventilator settings, if we are at the correct setting or not. So operator is the person whosoever is adjusting. So you would see that we are the one who's giving FiO2. Now, what is FiO2? FiO2 stands for fraction of inspired oxygen. So for example, on the ventilator is the one in which you can give 100% oxygen to the client, right? So in that case, what we're going to say, FiO2 is 100%. We never give like that much until and unless, the patient is completely desaturating. So we keep an average somewhere like, let's say 40% is the general average of FiO2, what we give it. Pressure, then you have inspiratory to expiratory ratio, PEEP, which is positive, and expiratory pressure. So all those things you can see is set by you. So it's just going to keep on following the same setting. It's going to keep delivering the breaths to the client at the, like, let's say if you have kept the FiO2 40% means 40. And let's say PEEP is for in this monitor, you can see the PEEP is 4. So PEEP is another confusion which people have is what happens is if you think about alveoli, it's just like a balloon, right? So when you inflate the balloon, it's going to, of course, inflate it, right? And when it gets deflated, right, what's going to happen? It's just kind of squeezing or shrinking, right? So sometimes what we want is we do not want those alveoli to shrink completely, right? Because then why we don't want it? Because sometimes it's for the next time, if we have to open the alveoli, we have to give a more high pressure respiration to the or like tidal volume to the client. So we don't want that. So to prevent the collapsing of the alveoli, what we do is we keep PEEP. So this means even if the patient is in the mode of expiration, what's going to happen? The alveoli will still remain open, right, at the pressure of 4 centimeters of water. I hope that helps. So so in this one, in nutshell, patient is not doing nothing, and what's going to happen is, as I said, it's the ventilator who is just doing everything for the client. Second is, guys, we have intermittent mandatory ventilation. IMV provides, now if you see here, what it does is it's a combination of mechanical assisted breaths and the spontaneous breaths, right? So this is a kind of a combination. You can just see that word combination, right? So I just want to show you the monitor here. So you can see that these were all your preset, right? So this was something which you set on the ventilator, right? You told the ventilator that you have to give this patient a breath, let's say every 10 seconds, right? So you can see that there is a gap of 10 seconds, 10 seconds, 10 seconds, 10 seconds. But in between those 10 seconds, you can see that what happened, patient also took its own breath, right? However, ventilator will still deliver its respiration, right? Its breath, right? So you can see here, it's still delivering it, right? So this means IMV is intermittent. So even if the patient is breathing in between, it's still going to give whatever you have set on that ventilator, right? So that's called as IMV. The last but not the least, the most important one, guys, which we use is, and this is something which I've used all the time in the ICUs, it's called as SIMV. SIMV stands for synchronized intermittent mandatory ventilation, right? So this is actually very, as the name suggests, what does synchronization mean? Synchronization means, for example, if you see here on the monitor, what's the rate you have set on the patient? 20, right? So you want patient to have 20 breaths per minute, right? But as I said, this is a very smart mode. Let's say your patient took 4 breaths, right? So what it's going to do is it's going to synchronize its breath with the patient's breath so that the patient only gets what? 20. So this means if the patient is taking 4 on their own, the ventilator will, let's say, deliver only 16 so that the total rate remains what? 20, right? So now why we love this mode, what's the benefit of this mode is, guys, it like if you look at the other modes where the ventilator is forcefully delivering everything to the patient, what's going to happen sometimes when your patients are like, let's say, recovering or coming back, or they have like a little bit of respirations, what's going to happen? The ventilator fights with the patient, right? So it's kind of a fighting, right? So that's a challenging situation. But in SIMV, we know that helps the patient to recover as well. That if the patient is getting better, patient has started taking more breaths, let's say 10, and then the synchronize is going to synchronize its system along with the patient's breath and only going to deliver whatever is required. It's not going to force something on the patient, right? That's the difference of SIMV. So that's something which is like highly used in the hospital settings. Now, coming to the fact about the nursing responsibilities, right? So I have just divided it into like, what is your pre-ventilation responsibility? So you have to prepare the client for intubation, preparing the ventilator as per hospital policy, and you will be assisting the physician with the intubation. Because intubation, guys, is not in nurses' scope of practice, not even in Canada. Like as RNs, you cannot do the intubation. You can do intubation probably like if you are a nurse practitioner, but not at RN level. So I know it looks huge, but don't get panicked. So simple things is what we need to focus on today because of COVID-19 is, guys, PPE, personal protective equipment. So if you know, like you're helping the physician for the tracheostomy, you should know that even the WHO guidelines is whenever you think the patient can generate aerosols. Aerosols are like small particles, right? You have to protect yourself. You don't want to get COVID-19. So then in that case, you need to wear like N95 mask, right? Gloves, goggles, gown, you have to protect yourself. But if, let's say, the patient is not producing aerosols, right? Let's say if the patient is just coming for testing. In that case, what we do is we treat COVID-19 as a droplet infection. So what we do is we wear the surgical mask and the shield on the top of it, right? So that's what we do. So your major role as nurses is gather the equipment, gather the PPEs ready, explain the procedure to the client or to the family, get the consent, right? A physician will get the consent, but you can be the witness, and then you will be assisting them with the intubation process, right? So once the intubation is done, your goal is to see that if there is like, you have to do assessment here, you have to look for the bilateral chest rise. You will look at the EtCO2, right, levels, ultrasound if needed, and you will be, as I said, continuously monitoring your client, right? So those are the simple things which you have to do as nurses. So during ventilation, if your patient is on ventilator, then what do you need to do in that case, guys? So here in Canada, what we prominently teach to our students is 60-second check. So this means whenever you will go and see the patient, what you need to do is you need to check the patient, you need to check the environment, you need to check the surroundings. So basically you are having a holistic check on your client within that 60 seconds. Then you will monitor the ventilation settings, respiratory rate, minute volume, spontaneous or tidal volumes, FiO2, ABG, and understanding the alarms, and then reporting, recording, and documentation is very, very critical here in Canada. It's like lots of legal issues, so documentation is very important. So troubleshooting the mechanical ventilation, I really love this picture. If you can see, so if you hear alarm, guys, don't do that. He's shooting a monitor, so you don't shoot a monitor. And don't close your ears. You need to figure out as nurses why that ventilator is beeping, right? So there are multiple alarms, but as I said, the class is very short, so I'm just going to touch on 2 alarms, high pressure and the low pressure alarms. So when you see that your ventilator is beeping and saying, it will tell you high pressure, what does that mean? High pressure means maybe there are lots of secretions, maybe your patient needs suctioning, maybe there is a kink in the tube, right? Maybe your patient is biting on the endotracheal tube, right? So when the tube is blocked, he's clenching his teeth or she's clenching her teeth, what's going to happen? The tube is getting blocked. Maybe when the patient is coughing, gagging, or trying to talk, right? In all those cases, what's going to happen? The monitor is going to show you high pressure, right? And another one is high respiratory rate. If the patient will be in pain, the respiratory rate can go up. If the patient has secretions, the respiratory grade can go up. Hypoxia, hypercapnia, all those things can cause high pressure alarms. Now, next is sometimes you see on the ventilator, it's going to say low pressure alarm, right? And most of the time, low pressure alarms are caused by if the ventilator tubings are disconnected or displaced, right? Low exhaled volume means, again, ventilator tubing is not connected or there is a leak or something is happening in the ventilator system. So quickly check for the tubings, settings, humidifier. So you're going to check for all those things in your ventilator. So those are my references. I hope I finished in time. I haven't taken much time, but all these are reference from medical surgical books, which we use, as I said, in Canada. And those are my references, and I used that for my presentation. I'm sorry, guys, that was pretty quick, but I am open for questions now.